Yeah, it's a privilege for me to be here in a platform wherein I was a student. It was like around 1 year back when I was doing FCPM, and I know logging in at 3 p.m. It goes on till 3:15. People will be on duty, and it's a wonderful thing that you are doing through these courses and through these online courses with which you are allowing people to learn from any corner of the world. And I understand that even international students have joined for this course. So we'll straight away go to today's session. And the topic given for today's session was elderly and vulnerability. Is the slide visible?
Yes, sir. Good to go.
Okay, thank you. So let's start with the topic itself, elderly and vulnerability. Now, I have a problem with the topic or the title itself because elderly is a term which is thought to be ageistic, and ideally it should be older adults. And in today's session, we will be talking about some concepts in geriatrics. I'll be giving you a snapshot of various concepts. And the beauty about geriatrics is that the same slides can be used to take the session for doctors, for nurses, for priests, for college students, because this is the sentence that I usually use in these sessions. As you might not develop a MI or a heart attack, so you may not require a cardiologist. You may not develop a stroke, so you may not require a neurologist, but you will definitely age. And that's universal, and that is bound to happen. And therefore, it's important that everyone, irrespective of their profession, knows what aging is, what healthy aging is. And today's session is basically on these concepts. So it should have been ideally older adults and vulnerable. So who is an older adult? It's my grandparents or my parents now. It's me in the next 30 to 40 years. So I need to know what happens when I age, even as an individual, more so as a healthcare provider. And I understand that allied healthcare professionals are the audience for today's session. Population aging is happening much more quickly than in the past. You can see that the time taken for the population older than age 60 to double is just 35 years. From 2020 to 2055, the number of persons or the percentage of the population above 60 will be the double that of what it is now for India. Whereas it has taken so long for France, Sweden, United Kingdom to double, but it is going at a fast rate in India. So we'll be having around 19% of our population will be elderly by the year 2035, according to the longitudinal aging study. And are we prepared for such a huge burden of older adults? And are we equipped, or do we really know what to do when we have such a huge population of older adults? So people are living longer. Previously, it used to be 60, now plus 20 years. Now, how do they spend these 20 years, these extra 20 years? Because age 60 is taken for maybe the social aspects like pension, etc., or the retirement age. But for geriatrics, actually, there is no age. So it all depends on the health of the individual, how he spends the next 20 years after 60. And health in older age is not random. Every 70-year-old is not the same. The level of performance, the functional status of one person is different from the other. So it's a heterogeneous group. So what makes us age differently? It's a genetic inheritance, who we are, and a lifetime of where we live, our health behaviors, our exercise patterns, the food we take, the dietary pattern, the stress levels, our access to healthcare, our financial background, our affordability to healthcare. So there are a lot of social, financial and health-related factors that determine our health in old age. There's no typical older person. Every older person is different from the other, and the functional self, the two words or two phrases that are very important in geriatrics are function and quality of life. It is our aim or our goal is to maintain the function of the person as long as possible. That is to enable him to do his activities of daily living as long as possible and to provide quality of life. So it's very simple when we talk about geriatric care. Now, the WHO has certain priority areas for action in the field of aging. One is to align health systems to the older population they now serve, develop long-term care systems, ensure everyone can grow old in an age-friendly environment. Age-friendly is a very key word in geriatrics, and improve measurement, monitoring, and understanding. A lot of time and lot of resources have been spent on mother and child care, and as a result of that, the population has the longevity and the life expectancy has increased, and that has resulted in a higher population of older adults. So what does it mean to align health systems? It is to place older people at the center of healthcare, to shift the care focus from managing diseases to optimizing what people can do. So there's a shift from disease-centric care to function-centric care, and to develop the health workforce. And today's session is also doing a small bit in developing the health workforce who know what it means to take care of an older adult. So aging, as we have discussed till now, aging is not a distinct phase of life which is disconnected from the previous life stage. It's called the life course approach. It's a continuum from infancy to adolescence to adulthood to older adult, and it is a continuum from what we have availed in the previous life stages. This is the study that I was mentioning. It's the largest study that has happened in any country. It's the largest longitudinal study on aging which has happened in India, and the first report came about last year, and it estimates that by 2050 about 19.5% of India's population would be older adults, and this is because the life expectancy has gone up and the fertility rate has come down. The total fertility rate has come down and the life expectancy has gone up. The years 2021 to 2030 is the UN Decade of Healthy Aging. So every organization of importance is looking up to this area of aging and geriatrics, because the needs of these people are very different from a normal adult. So it aims to create a generation of older adults who are healthy and active, seek to change how we think, feel, and act towards age and aging, and a generation which is devoid of ageism, with an attitude to create an environment equal and friendly for all ages. That is an age-friendly environment. So this is what the broad goals of UN Decade of Healthy Aging is. That's from 2020. And what is healthy aging? Healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. So again, we come to that term, functional ability. It is the core of an older adult. So our aim would be to maintain the function of the person to carry out his activities of daily living. For starters, geriatrics is the care and treatment of older adults, and gerontology is a scientific study of the aging process. So older adult population is a unique group with complex problems which require special skill sets to appropriately manage and coordinate the care among various specialties. And so in modern medicine now, it is multi-specialty, super specialty, multi-consultant care, and with the burden of multi-morbidity, multiple diseases in the same person, having diabetes, hypertension, chronic kidney disease, chronic liver disease, movement disorders like Parkinsonism, stroke, they will have multiple consultants who will be seeing them, a nephrologist, a neurologist, a cardiologist, and they will have multiple prescriptions, multiple caretakers, and healthcare providers, which makes it a lot complex to solve, and such multi-specialty, multi-consultant care results in lot of adverse effects as well, which we'll be dealing with in the coming. So geriatrics is a branch which requires importance in the same line as pediatrics with regard to the subset of patients they cater to. Because as a child, a 5-year-old child is not a smaller version of an adult. An older adult is not a grown-up adult as well. Also, so the needs of these people are different, and the skill sets required to take care of them is also different. As with palliative care, geriatrics is also a team-based, person-centered care which applies the principles of robust clinical practice. The challenge is unique in that the aim varies in each patient. It's a personalized care. You cannot do the same thing for everyone. Every older adult is not the same. The needs of the person will be different. The wishes of the person will be different. This might involve uncovering a typical presentation of a medical illness, pruning medications that are unnecessary, identifying social and psychological barriers, etc. So that's why palliative care as well as geriatric care have a common team-based multidisciplinary approach to patient care. At other times, the principles of palliative medicine may have to be adopted. In all these instances, the priority of the geriatric team is on ensuring that older people enjoy the best possible quality of life. Again, we come to that term, quality of life. So function and quality of life. How is geriatric care different? We need to have more time with the older adult because they have so many things to say beyond the obvious clinical science. So patience is a word which is required if you are going to cater or care for older adults. Clinical signs are mostly unusual. Actually, atypical presentation is the rule than an exception. And clinician must think beyond conventional learning of disease or organ-specific disease or symptoms and approach the person or the body as a whole. So from organ-specific approach to a holistic approach is required in geriatric care. And understanding the needs of the older adults helps you to deliver the quality of care that they are expecting rather than the kind of care you think they might want. So there's a difference between what they expect and what you think they might want. And by providing age-friendly care, it is professionally satisfying. You are contributing to better health outcomes for older adults, which is a win for everyone. It's also a satisfying experience. As I said, you can feel good knowing that you not only contributed to the better health outcomes, but you contributed to making older adults, their caregivers and their families feel really good about the kind of care you provided, as with palliative care. So alleviation of suffering. And I believe as healthcare workers, our job is facilitation and alleviation of suffering. Though the definition of palliative care has alleviation of suffering in it, actually it applies to any part of healthcare because it's the suffering that you alleviate by the science and art that you have learned, irrespective of which specialty you work in, and more so in geriatric care. Now, this is what our older adults had to say and what they expect. We don't want our healthcare providers to tell us that it's all because of our age. I want to feel as if you are talking to me as an individual with my specific needs and not just as other older persons who are all alike. Not all older persons are not the same. We want interaction with providers rather than pamphlets. We want providers to be informed, positive, encouraging, and engaged. Be respectful, inquiring, culturally sensitive, and not condescending, and be personal. Get to know me and don't be rushed. Then it's easier for me to share. So it's important as healthcare providers to know what your older adult feels when you. So these are important aspects of communicating with an elderly person or an older adult. See, that word definitely comes in, elderly. And I have been trying not to use it, as I have been very consciously trying not to use the word bystander. See, bystander is someone who is just looking upon things happening. And we use the word bystander in healthcare very often. Actually, the word is caregiver, because he's the one who is taking care of the person 24/7. And I, as a doctor, am just seeing him for rounds and maybe discussing things and making arrangements for his medical care. But the person who is by the side of someone who is bedridden, he's the caregiver and he's not the bystander. And we have made it a rule not to use the word in our hospital as well, in all the specialties. But still the word comes in as with elderly. So it's evidence-based disease-centric care versus patient-centered care. So the patient tells you to include him because it's his problem or her problem that you are trying to solve. And he is the most important person in this. Some age-related changes that we have to be mindful of, especially when we are communicating with an older person, is that there is problems with the mind. They have increased time to recall or learn new things and decreased reaction time. So give them time to respond. Don't bombard them with a barrage of questions when you are interviewing them. Be patient, allow them to come out with their problems and their answers. They will have decreased ability to focus, difficulty adapting to changes in light levels, decreased ability to resist glare. There will be problem with hearing, difficulty hearing high-pitched sounds, increased sensitivity backgrounds. So what often happens is when you find that your older adult or older person sitting in front of you has some problem hearing, you tend to shout. Don't shout. Shouting doesn't help. Actually, it puts off the patient because he feels offended and you might think, why this person is shouting at me? More than shouting, what we have to do is to talk slow and low and talk clearly and wait for the response. Ask him if he has a problem with hearing and which is the better ear. So talking closer to the better ear would help. Decreasing the background noise would definitely help, especially in ICUs. So they will also have decreased physical strength, decreased balance, coordination, and such changes in the senses make them vulnerable to adverse events. So from communication with the older adults, we go to the next concept, and which is a very important concept, a simple concept, which you can remember. It is called the 5 M's of geriatrics. The 5 M's, one is what matters most, second is mind, third is mobility, fourth medications, and fifth is multi-complexity. What matters most? Mind, mobility, medications, and multi-complexity. In mind, there are the 3 Ds, that is dementia, delirium, and depression. When it comes to older adults, there is age associated cognitive decline, but more morbidity and mortality and suffering is associated with dementia or memory disturbances. Delirium, we will be coming to it in detail, little detail, and depression. And these may go unrecognized and undetected for long, causing a lot of problems in lives of older adults. Second is mobility, because mobility is what keeps us going, keeps us, helps us to do our activities of daily living. So the amount of mobility or function that the patient has he got an impaired gait and balance? Fall injury prevention. Falls is a major, or it's a geriatric giant, and fall is something that can result in significant morbidity and significant decline in the functional status of the patient and mortality as well. Medications. Polypharmacy is the dictum in patients, especially when they are having multi-morbidity. So deprescribing and optimal prescribing in patients to reduce the adverse medication effects and medication burden is important. But over and above all this, what matters most is the driving force behind the 5 M's. That's each individual's own meaningful health outcome goals and care preferences. And multi-complexity. It's a typical older adult living with multiple chronic conditions, advanced illness with the complicated biopsychosocial needs, as I had already said, with multi-consultants, multi-discipline, multi-prescriptions, polypharmacy, and all these are interrelated as well. So what matters means to know and align care with each older adult's specific health outcome goals and care preferences, including but not limited to end of life. So it is not limited to the end of life care that we are talking about what matters to him, and across settings of care. Medication, if a medication is necessary, use age-friendly medications that do not interfere with what matters to older adults, do not interfere with mobility or mentation. Drugs like benzodiazepines that you give for decreased sleep can result in drowsiness, can result in delirium, can result in drowsiness, and which can lead to falls in prone patients, and that can result in a fracture, and that can result in hospitalization. Hospitalization can result in a functional decline, can result in sarcopenia, can make a patient who was moving around bedbound by a simple trivial fall. Mentation or mind to prevent, identify, treat, and manage. So identification of these, the 3Ds, dementia, depression, and delirium across settings of care. So we might have to screen for dementia, screen for depression and delirium to identify them, treat and manage them, because they are associated with a significant morbidity and mortality, especially with depression, with COVID, loneliness, social isolation, and they may not present as depression itself. They might present with multiple psychosomatic or multiple somatic symptoms, fatigue, and they might be. So it is important to know the person as a whole to manage or to detect the 3Ds. Mobility, ensure that the older adults move safely every day to maintain function and do what matters. And what matters could be as simple as going to a place, meeting friends, or maybe having children, visiting them. So there are a lot of social aspects to geriatric care as well than the medical aspect that we see in hospitals. So what matters is the driver, medications, mobility, and mentation. Mentation having dementia, delirium, and depression. I am repeating these slides because at the end of the session, I definitely would like to know that you have these 5 M's in your mind when you go back after this session. So what matters to the older adult is the basis of the age-friendly healthcare, and the change the conversation from what is the matter, which we usually ask, to what matters to you. So what matters most means what gives us joy, happiness, meaning in living, the purpose of life. In older age, the purpose of life becomes very important, and that is what keeps all of us going. And having a purpose in life is very important to having better outcomes for your diseases as well, your multi-morbidity as well. So there is a psychological aspect to every disease and multi-morbidity. Treatment and care of disease, illness conditions, so that is related to healthcare and health or ongoing health concerns and conditions. And this is personalized. This is not the same for every person. Medication, I said, there will be polypharmacy. How many is too many? And polypharmacy is defined as 5 or more regular medications that they take. And it is said that the 6th regular medication increases the risk of adverse events. And you would definitely be able to relate this to one of your relatives, your parents, or your grandparents. They are having these problems of multimorbidity and polypharmacy. Now, coming to mentation, dementia, delirium, and depression. Dementia and the problems associated with dementia for the patient, more so for the caregivers, the burden of caregiver stress that is associated with dementia is huge and usually unrecognized. And a demented patient, most of the times people will be focusing on the patient, but the caregiver who is by the side, who is giving the 24/7 care, is the most important part of treatment of dementia, which is irreversible. There are certain reversible dementias as well. They are often unrecognized and untreated and associated with increased morbidity, mortality, and cost. So it is important that healthcare providers at all levels know what dementia, delirium, and depression is, how to recognize them, and be trained so that it is recognized at the earliest and taken care of. Delirium is a medical emergency and preventable. There are 2 slides on delirium because if you are having elderly at home or older adults at home, they might also have problems of delirium, and you might have, actually, when I give you examples of what delirium is, you will be able to relate to what you had seen or what you have heard your relatives tell how their 85-year-old mother had behaved when she had fever or when she had a urinary tract infection. So some risk factors that predispose someone to delirium or precipitate delirium are advanced age, dementia, sensory or functional impairment. So hearing impairment, vision impairment, decreased nutrition, and malnutrition may be related to a sharp teeth, which is causing problems with the tongue and pain, and that would have resulted in decreased intake, dehydration, urinary retention, constipation, infection, medications, metabolic disorders, substance use disorders. All these can precipitate delirium in someone who is predisposed to it. Now, identifying delirium. Here I have put some examples of how delirium can be picked up. So the following codes are examples of what might happen if someone is suffering from delirium. These are the codes of the caregivers given to the healthcare workers. So after her hip operation, my mother became very confused and aggressive. She kept pulling out her drip and shouting at nurses. It was a shock, as she is usually so polite. So it can be frightening for the caregiver or for a daughter or a son when to see their mother behaving in an aggressive way, pulling out things, trying to jump out of the bed. And it is important to identify or know that this is delirium, and I have to address the precipitating factors to treat it. And it is not sedation that works for delirium. It is not putting them to sleep, because that actually worsens delirium. We can often tell them that my father is getting a urinary infection because he starts to get slower and becomes quiet and withdrawn. So a son who has been taking care of his frail father, they would the caregivers would start identifying these signs of, okay, my father is going in for hypoactive delirium. He also sleeps much more. We were told the slowness, quietness, and withdrawal are actually delirium symptoms that have happened as a result of it. So delirium can have two spectrums. It can be either hyperactive or hypoactive and or mixed ones. So hyperactive is when the patient doesn't talk at all, he's sleeping all the time, he doesn't respond to stimuli. And hyperactive, on the other hand, would be the patient be aggressive, trying to beat up, will be shouting. And usually the hyperactive delirium gets picked up earlier because people notice when somebody is aggressive. But hypoactive delirium is more dangerous than hyperactive. And it is fluctuating. It fluctuates from hypo to hyper. The third one, my wife has mild dementia, but we usually manage fine at home. She still recognizes most of our neighbors and friends. When she was in hospital, though, she didn't even recognize me or our daughter. So hospitalization for dementia patients, when they get admitted for infections or any other medical problems, that itself can precipitate delirium. The nurses told me that my grandmother had been up all night wandering around the ward and trying to leave. However, when I visit her on the ward in the daytime, she's nice and quiet and seems okay. So delirium has something called dawn effect, or sundowning phenomenon. That is, the delirium becomes worse at night. So when we come for rounds in the morning, the patient will be very polite, talking to us, telling his problems. But at night, he becomes aggressive, and that is the way delirium behaves. And my father became very confused. He was sleepy at times and agitated and restless at other times. The nurses gave him medication to help control symptoms. And medications for control of delirium would be given only when the patient becomes a threat to himself or the healthcare workers or the caregivers. Then small doses of antipsychotics can be used, but it is not the treatment. It is used only for such events. What not to do in delirium? Don't think delirium is a benign condition. Don't keep waking patients up at night. Don't stick tubes into patients that they don't need. Don't catheterize or cannulate unless you really have to. So interventions in elderly patients and older adults have to be well thought out, because it can precipitate delirium. So with good night's sleep is important. So doing investigations at night, changing them from one ward to other, taking them for x-rays, all have to be planned during daytime, because at night, if it is done, then it can precipitate delirium. And antipsychotics are the last resort. Who are the vulnerable older adults? Those are the dependent. They could be financially dependent, physically dependent, memory impaired as the dementia. Those with limited income or limited sources of income, with limited mobility, as with the 5 M's, inadequate housing, social isolation or exclusion, with communication barriers, and with less access to appropriate health and long-term services. These older adults are vulnerable to adverse outcomes. So the risk factors that make the older adult vulnerable are injury, like falls, nutrition deficit, malnutrition, undernutrition, social isolation, dementia, sarcopenia, which is another geriatric giant, and compromised immune system. So from the 5M's concept, now we go to another concept called the frailty syndrome. And this frailty factor is what decides on how an older adult would respond to an adverse event like a urinary tract infection or a pneumonia. It's not the same for everyone. So people have researched and found that there's something called frailty, and aging, frailty, and palliative care. And palliative care has a very important role to play in frail older adults. So what is frailty? Frailty syndrome is characterized by the reduced physical and cognitive reserves and makes the older adult more vulnerable to adverse events such as hospitalizations, falls, loss of independence, and death. So it is the reduction in the reserve, the physical and cognitive reserve to fight stress. When there is a reduction in this reserve, that results in adverse events, or it makes them more vulnerable to adverse events like falls and hospitalization. And as with COVID-19, we had seen that the older adults were succumbing more to the complications of COVID-19, and that is because of this frail status. The association with frailty syndrome and other characteristics are advanced age, female gender, presence of 2 or more comorbidities. Polypharmacy has a significant role in making a patient frail, functional or cognitive disability as in dementia, a low body mass index, obesity in the elderly, depressive symptoms, and the self-evaluation of poor health has been associated with the frailty. There are many tools that have been used which are useful in one way or the other. The frailty phenotype has shown association with major outcomes like first hospitalization, first decline, disability in the activities of daily living, worsening of mobility, and death. That is, there will certainly be impacts on the quality of life when frailty sets in of the older adults. This results in an unsuccessful aging. And as is often the case, in the absence of possibility of care, their cure, their death. So frailty is the one that results in a decline in the functional status of the patient. Now, frailty and palliative care. It is in this scenario that the number of frail older adults could benefit from palliative care sooner rather than later in their disease course. Palliative care is not something that has to be given at the end of life, but it has to be started at the beginning of frailty. It is essential that relief be provided for the suffering caused by the various diseases that over time have taken away the health and lifestyle of both the elderly person and his family, which is worsened by the loss of the elderly function. These are quotes from the study that I have shown earlier, which shows a relation between frailty and palliative care. An example would be a fall in a patient with Parkinson's disease, resulting in fracture neck of femur and resulting in bed-bound status after surgery. And the return to walking with the walker or without support would depend on the frailty status of the person. And adequate and quality palliative care, when initiated at the onset of fall, has shown to improve outcomes in patients and quality of life than provided at the end of life for them. So palliative care has to be initiated at the earliest, and if not for all older adults, it's not possible for all older adults, but it is important to identify frailty and to start palliation at the earliest to provide better functional status and to provide better quality of life. The next concept here comes with the comprehensive geriatric assessment. So how do we know whether this patient would require care early enough? For that, medical assessment would not be enough. They need a functional assessment. They need an assessment of mobility and balance. They need a psychological assessment for dementia, a medication review for inappropriate medications, a physical assessment, a socioeconomic and environmental assessment with palliative care. So multiple domains have to be looked into, and this will require multidisciplinary approach. It cannot be done by a single person at a stretch. It might require multiple sittings, and combining all this, we create a problem creation of problem list happens. We create a personalized care plan, and then we provide interventions and regular planned view of the interventions. And the interventions will depend on what matters to the patient, and something that had a significance in the past may not be relevant now, depending on the functional status of the patient at this time. So it is a longitudinal care that happens after a comprehensive geriatric assessment. One of the models of identifying frailty is the Fried et al. Model, which has 4 criteria, one being unintentional weight loss of 4.5 kg or 5% of body weight in the last year, self-rated fatigue, assessed through questions and the depression scale of the Center for Epidemiological Studies, reduction of palmar grip strength. The grip strength has been associated with, has been shown to be related to frailty, measured by a manual dynamometer, which is a very simple instrument that can be used, the dominant upper limb, and reduced level of physical activity measured by weekly energy expenditure in kilocalories and decrease in walking speed. So gait speed has been associated with frailty, and a person might have one or the other in alone, and that doesn't make him frail. And according to the Fried et al. Criteria, the presence of 3 or more criteria makes them frail. 1 or 2 criteria makes them pre-frail. That means they are prone for adverse events in the future. And it is based on sarcopenia and immunological and neuroendocrine changes, and focuses on the physical dimension of frailty. So one model that I would like to quote here is the Fried et al. Model of frailty. Another vulnerability that they have is the age-associated financial vulnerability. The multiple factors lead to financial vulnerability in the older adults because of a decrease in cognition, the cognitive and emotional domain, or the medical and functional domain, a psychosocial domain, and the environment and societal. So these are the 4 important domain factors that are taken care of in the comprehensive geriatric assessment. And someone who has dementia may be exploited financially by the caregivers, by their children itself, or by their relatives. They might have progressive illness. So advanced care planning, I think the session on advanced care planning is planned in this course. So importance of advanced care planning becomes important. Advanced financial planning, advanced medical care planning becomes important. Advanced medical directive becomes important in these, because of these factors. So again, we come back to evidence-based disease-centric care versus patient-centered care. So it's important to know what matters to him and what he really wants to do, because you have lived a life like a king till 85 years. And once you start to have a cognitive decline or a functional status decline, and once you start to become dependent, your autonomy on deciding what you want is also very important. And it is important to include him, because it's important to give him the opportunity to say what medical care he would like to have, what end of life care he would like to have in case of irreversible situation. So where is the person now? It is important to assess where the patient is, especially when decision making and care of older adults with multiple chronic conditions. At this point, we have to see whether disease-specific evidence-based guidelines are applicable, organ-specific guidelines are applicable. If yes, if it is more than 10 years of life, few conditions, who is functionally fit, who has independent for his activities of daily living, then definitely disease-based guidelines as consistent with patient preferences have to be used. But if it is no, that's in patients who have a less than 2-year life expectancy, who has an advanced end-stage disease like an advanced heart failure, an advanced liver disease, advanced dementia, cancer, etc., then it is important to de-escalate organ-specific treatments and to initiate on palliation, palliative care, symptom management based on what matters to the patient, what personal preferences you'd like to have. And this is the area where we would have more planning when it is uncertain whether the disease specific guidelines are applicable or not. There are shorter life expectancy, but increasing severity of condition. There's an impaired function. And here the patient priority aligned care or the current care planning becomes very important. This slide is very important in the new world of modern medicine to know when to stop, when to have a stop on the unnecessary medical interventions that can happen, which puts a lot of financial as well as social burden on patients and caregivers.
Dr. Anish?
Yes.
Can we stop for a while, because many participants are having confusion with some of the terms you use. So to all participants, if you have any questions to be asked right now, we can address it right now and then move on to the rest of the session.
Okay. So was it put in the chat box? Okay, I see it now. So we will stop for a while. If there are any queries, we will clarify them and then go forward.
There were questions regarding mentation, delirium, and I think that was before the slides was there. So I think that was cleared. And then they talked about ADL. One person said it is activity of daily living. And then they asked about Palmer grip.
Okay. Right. So activities of daily living means what we do every day, from getting up from bed to going from bed to chair, brushing, combing, toileting, bathing, having food. These are the activities of daily living of a human being. So our aim is to make sure that our patient is able to do all these things. So that is ADL is activities of daily living. Now coming to Palmer grip, what I would like to clarify here is that I am only introducing these concepts in this session because it is not possible to go into details of each of this. So my idea is definitely not to give you a class on how to do frailty assessment, because frailty assessment itself is a very complicated area, especially because it has to be culture sensitive and it has problems with the language. So it has to be adapted to our native language before we apply this on our population. So Palmer grip, it's a dynamometer, it's a small device that we use to measure the Palmer grip of the patient, hand grip, and it has been associated with, or it has been proven that it has got significant, but a Palmer grip alone is not enough. And this is only one of the tools that we use. There are umpteen number of tools and which have been proven to be effective, which have been proven not to be effective. And in Indian population, actually studies have not been done so far, or there have been not many studies on frailty assessment, and but it is important. So that's why geriatrics and the awareness about geriatrics becomes important, especially in our country.
Dr. Anish,
yeah.
My name is Lakshana. Sorry to interrupt. This is a very useful session. There's a lot of information you're giving us. I think you may be going just a little fast for us, for some of us to catch up, because not all of us are from the medical background.
So is speed a problem?
If you could just give us, just take it a little slower so we have time also to absorb what is being shown on the slide.
Yeah,
I may be speaking for myself, but it's just a little faster.
I have this problem of going fast when I speak about things that I'm interested in. So I know. This is a common problem in my presentations, and thank you for pointing it out. I'll go slow.
Thank you so much.
And actually, we are coming to the end of the session. So if you want to go back, I'll definitely be happy to go back on slides that you had clarifications. That's why I have put only little things. I have not gone very vast into the topic. I think only a few more slides are left.
Okay, thank you.
Okay. Any more clarifications about what we have dealt till now?
Yes, sir. Yes, sir. Thank you, Lakshana, for bringing that up. So, sir, we also have a question. What is the age when we need to start geriatric care?
Yeah, that's what I think I said that, but maybe because of my speed, we didn't pick it up. Actually, there is no age wherein geriatric care starts. the age internationally is 65 years or older when you are called a geriatric person. But in India, it is 60 years. But these have been kept based on the social aspects, like the social security schemes, the pension schemes, the age of retirement. Because we could even have a 55-year-old who has multiple diseases like chronic kidney disease, diabetes, hypertension, peripheral neuropathy, peripheral occlusive vascular disease, or liver disease, kidney disease, heart disease, who is having problems with functional status and who is dependent for his activities. So age, more than age, the function becomes important. When have you become dependent for your functional day-to-day activities? So a geriatric care becomes important when you start becoming dependent for doing things by yourself, when you start developing problems with cognition, like problems with memory, when you start developing problems in carrying out your day-to-day work with which you earn your money. So at that time, it is important that you are taken care of by a geriatric team, because so many things have to be put in place to make a plan for you. So age-wise, it is 60 or 65, but more than age, function is important. The cognitive function, the physical function, the functional status, what do you say? That's the ADL, activities of daily living. I'll again repeat the ADLs. This is how I remember it. What I do after getting up from sleep. I get up from sleep, I get up from my bed, I go to the bathroom, I brush my teeth, I do toileting, I bathe by myself, I dress myself up by myself, nobody helping me. I comb my hair, I groom myself, I go to the dining table, I have my food by myself. So these are things that keep me independent for my daily activities. So if an older person is able to do all these things by himself, he's at a better place, he's better placed in the functional status. Any other queries?
Thank you, sir. One more in the chat. What is the
Yes.
difference between the Alzheimer's dementia and Parkinson's?
Okay. So I have not touched dementia at all in this presentation except for those slides, because dementia itself is an area that requires a lot of awareness, especially with this increasing older adult population. So dementia means, to put it simply, you have problems with memory. You forget things. We also forget things, but you forget things which are very common in your daily day-to-day activities. That is, memory disturbances that are affecting your activities of daily living. Like, I forget that I had food 10 minutes back. I forget that my way to my room. And it is a chronic disease, but there are many causes for dementia. There are reversible causes. There are some infections. There are metabolic problems like loss of low sodium, high thyroid diseases. All can also produce memory disturbance, but these are reversible. So it is important to pick memory problems at the earliest, so that we can look at things whether there are reversible factors which can be treated and dementia becomes reversible. But commonly the term dementia, especially with common people, it is used with Alzheimer's dementia. Alzheimer's dementia is a neurodegenerative disease. That means it is destruction, or you lose your brain cells. It is a disease which has no cure as of date. It is a disease which can be controlled, which can be managed, and which the progression of the disease can be controlled. But you can't cure Alzheimer's dementia. There are other conditions also that produces dementia, but Parkinson's disease. So I was asked the difference between Parkinson's disease and dementia, right?
Yes, sir, I guess so.
Yeah.
Yes.
So Parkinson's disease is again a neurodegenerative disease. That is, you lose your cells in the brain, but that affects your mobility. Why Parkinson's and Alzheimer's come into discussion in older adults is because these are degenerative disorders. Parkinson's affects your mobility. So from the 5 M's, Parkinson's affects your mobility, and Alzheimer's dementia affects your mentation, mind. So mobility means you tend to have tremors, you become very slow in your gait, you will have difficulty in carrying out your ADL again. I'll have difficulty in going to bathroom by myself. I tend to fall often. I develop fractures. My gait becomes slow. The pace with which I do my things, I take more time to eat. So it is usually the caregivers or the relatives who identify this first than the patient. They bring patients to us saying that my father has become very slow in his activities. He seems to be very dull these days. So that's their observation. And when we examine, we find that there are certain signs which are consistent with Parkinson's, like tremor, a resting tremor. They will have tremor when they simply sit. They have rigidity. That is, there's an increased resistance when we try to move their limbs. They have slowness of gait and such things. So it's a clinical diagnosis. And again, you try there's something called Parkinsonism and Parkinson's disease. Now I'm talking about Parkinson's disease, which is again a degenerative disease, which happens because there is a decrease in chemical in your body called dopamine. So there are medications that can increase the dopamine levels in your body, like Syndopa, levodopa, carbidopa, which we give, which increases the dopamine levels. So the patient will be able to do things by himself. So it improves the quality of life. But again, as with Alzheimer's disease, it's a disease that progresses, but it happens over years. It doesn't happen over 1 or 2 years. It happens over 10 or 15 years. And the unfortunate part is that if this is not picked up early, patients might present to you with advanced disease, wherein they would have already developed complications of the disease, like aspiration, infections, etc. And at that point, treatment becomes futile. So Alzheimer's, dementia and Parkinson's are two entirely different diseases. But the problem with Parkinson is that as age advances, with increasing age years of Parkinson's, they can also develop dementia. So by 5 or 10 years of Parkinson's disease, patients with Parkinson's can also have dementia. So now again, you can see that 5 M's comes from the picture. Somebody who has problems with mobility now will have a problem with mentation as well. So hope I am clear in this.
Thank you, sir.
And I don't mind you asking questions, because I actually enjoy being asked, because it's also a test for me. How simply can I tell this to people?
Yes, sir. We got a response that well explained.
Thank you.
So is there any other pressing questions we have to take right now? We can do it. Otherwise, we can move on to the session and take the rest of the questions at the end.
So just a kind of reconfirmation, am I audible, sir?
Yeah, sure.
Yes,
Yeah. So like you mentioned that there are those two kinds of dementia. However, my father had got all of that. Like there was dementia, there was Alzheimer's, there was dementia, Alzheimer's, Parkinson's. That's how the doctor had diagnosed him. So that is also possible, like you mentioned, that it progresses on to get the other M's also into place.
Okay.
Right, sir?
So
Just understanding.
It depends on what came first. If the person had memory problems and mobility problems together, there is another spectrum called the Parkinson plus syndromes. So I kept the medical terms a little away from this, because I was told that it is allied healthcare workers, but I can understand because you'll be able to relate it with your relatives. So I will explain it. So Parkinson's plus syndromes, there are other types. Alzheimer's is only one type of dementia. There are other type of dementias where you have features of Parkinsonism with dementia, like Lewy body dementia. Lewy body dementia is where you will have problems with walking, you will have rigidity, you will have hallucinations. They will start seeing things which are not there. They will start responding to things which are not there. They will start beating up people who are standing in front of them. They might just break through the window. So they will have hallucinations. They will start seeing things which are actually not there. So that's called Lewy body dementia. There are other Parkinson's plus syndromes like PSP, progressive supranuclear palsy. So these are all groups of diseases. But if a patient was diagnosed with Parkinson's first and without any memory problems, and as years pass by, he starts to develop memory problems by about 5 to 10 years, then it is possibly Parkinson's disease associated dementia. So dementia is not a single disease. It is actually a spectrum of diseases. It's a group of diseases. There are other type of dementia called vascular dementia. That happens in people who had stroke. There are multiple strokes that happen. There will be multiple infarcts in the brain. There are infarct means there's decreased blood supply to different parts of the brain, and they might also develop features of Parkinsonism with memory disturbances and behavioral problems. The problem with dementia syndromes is that they will have behavioral problems. They will have aggressiveness. They might have agitation. They might not take food. So it is like having small children at home, 1.5 or 2-year-old, and the caregiver is the most important person in the life of a person who is living with dementia.
Thank you, sir. Thank you, sir.
Okay.
So I think we can move on with the session and then take the questions in
Okay,
between.
thank you. So as this is a slide which has touched me a lot, because we are seeing this a lot nowadays. So you live like a king till 85, 90 years, but you die lonely. You die with a lot of tubes in your mouth, in your urinary tract. You have machines connected. So it is also important, as it is important to live the way you want, it's also important to die in dignity. So a dignified death is also important. And for that, early planning, because when you start to see the decline, when you start to see the functional decline, death is inevitable. So it is easier when the medical professionals also help the family and the patient to plan. And when the patient preferences are taken care of, especially when they have no cognitive decline at that time, it is easier to make them, or it is easier to prepare them for the end of life. I have just put this slide here to know, so you take care of your mom, but who will take care of you? Because so informal caregivers, as with palliative, as with cancer patients, as with palliative care that we see, it's the caregiving, the informal caregiving is very important in a country like India. But as the families are becoming smaller, as nuclear families are setting in, this informal caregiving also becomes a problem. But if you might be taking care of your mother now, but who will take care of you? Who will be there at that time? And caregiving and caregiver stress is an important aspect of, because it's a teamwork. It's a team of healthcare providers. It's a team with the healthcare provider, the patient at the center, with the caregiver having the most important role, especially if the patient has dementia or has become totally dependent for his activities of daily living. There are a lot of tools available, not Indian tools though, which can be used by laymen, by general people, by healthcare providers. One of them is the senior friendly care, wherein they address all these problems of delirium, mobility, continence, nutrition, pain, polypharmacy, social engagement. So they give a lot of management tools for older adults and their caregivers, which is freely available in net, which you can access and go through, and it makes a difference in the way you give care to your older patients, the way you look at your older parents and grandparents. It definitely makes a difference, because geriatrics is a part which is as palliative medicine, which is often very much neglected in the curriculum, and it is definitely neglected in the MBBS curriculum. And I should suppose that it's the same with other allied health sciences as well. But as we have seen, as with the problem statement of increasing aging population, it is important that we become aware of these problems, not only the healthcare providers, but also the general public, the younger generation, the college students, they become aware of what happens when we age. So again, to reinforce, there are the 5 M's matters most: mind, mobility, medications, and multi-complexity. The goals of care are to keep them as functionally independent as possible, provide quality of life. It's about adding life to years and not years to life. It's not about keeping people alive for years and years, but to keeping them alive with appropriate quality in life. Above all, geriatrics requires a fondness for the old people. It is not a specialty for those who are all business and who must move quickly to the next problem. You need time in geriatrics. Geriatric problems frequently have no solution. The physician's attitude is his best therapeutic instrument. I might spend about 30 to 45 minutes with one patient, if it's a new patient who has come to my OP, and I might send him on just paracetamol 650 milligram TID for 5 days for his back pain. But the actual treatment is the 45 minutes that I give to just hear out his problems. The multiple problems, the multiple things that he had to say. There are a lot of crying spells that happens in a geriatric OP, but it is part and parcel of being a geriatric OP. So with it, he may disperse discipline, humor, seriousness, solicitude, reassurance, cajolery, and praise. Through listening to chatter, he may learn more about his patient than by direct questioning. It's about all hearing them out. The geriatrician must graft his humane instincts onto the hardy roots of gerontology, which embraces all the sciences. So geriatrics and gerontology is not about the patient, but it's about you. And that's why it's important. You are going to reach this stage at one point when you would like to have people who are age-friendly, taking care of you, who what matters to them today will matter to you tomorrow. So thank you for your patient listening. And this is height of positivity. A reporter was interviewing a 99-year-old and he asked, I certainly hope I can return next year and see you reach 100. And this, so you get such witty answers in your OPD. Why not, young man? You look healthy enough. Thank you.
Thank you, sir. That was very detailed session. So I think it's time for us to look into some of the questions and clear doubts, and
So,
also we can.
I am not. Shall I stop sharing, or if anyone wants to go back to any of the slides, we can definitely do it before I stop sharing the slides, or we will have a discussion after stopping. Either way, so.
Yes, sir. So if any slides should be re-shown, we can do it now. So you can unmute from your end and speak rather than typing in the chat.
Myself, Rachel. Actually, I missed the initial parts. See, can I know where this Amala Geriatrics is? Because I'm based in Trivandrum, and I have a group of friends who are lonely and are facing problems.
So Amala Institute of Medical Sciences is in Thrissur, in Kerala. And,
do you have any geriatric center in Trivandrum?
In Trivandrum, no. Actually, geriatric centers are very less, to be frank. But Trivandrum Medical College has a geriatric center. Actually, it is one of the regional geriatric centers.
Okay.
Trivandrum Medical College.
Okay. Thank you, Tom.
I had a question as well, which I typed out, but let me ask it.
Yeah.
So this SF7 that you mentioned as a resource, when you were talking about it, you said there aren't any, or there are very few Indian resources. But of the few that are there, what would you recommend that we look at for further understanding if there is such a resource available, India specific?
Yeah. See, SF7 is why I put SF7 here is because there are resources for caregivers as well. So even if healthcare professionals read them, it will also help. And SF7, I would recommend SF7 actually. There are a lot of resources. There are PowerPoints. There are resources for administrators, for people to teach how to have a senior friendly care. And SF7 has a lot of resources for that. And it can be applied to us. See, what I meant was resources which have been published from Indian authors are not there, but
Okay.
human beings are the same everywhere. So
True.
it is useful.
That actually brings me to my second question, because a lot of, even in palliative care, like approaches to death, grief, bereavement, there's a lot of cultural aspects to India. So are there any cultural aspects to geriatric care in your experience that you've come across, which may be unique
Definitely,
to India?
there is definitely that cultural aspect of it, that applies to any aspect of healthcare, because the way an elderly would like to be addressed in Delhi will be totally different from how I address him in Thrissur. The language, because see, when an 85-year-old man comes to my OP, he's 85 years of experience, and I am not even half his age. So it's important how I communicate with him, what the kind of rapport he doesn't care whether you are a doctor or whether you have MD, or something. Your degrees don't matter in a geriatric OP. What matters is how you made him feel during that brief session that you had. So the cultural aspect becomes very important. It's really important. Yes, it is.
Okay.
And the more you practice geriatric care, the more you learn. The more you learn how to adapt to your population. But the principles remain the same. The principles of communication, the principles of hearing, and I forgot to tell about the 90 seconds of silence that you need in communication. What I usually do is I look at the OP and I just confirm that it's the same patient. And then, okay, tell me. And I just keep quiet. You will have all the problems coming out in the next 1.5 minutes. And that will contain the solution also. So you should not interrupt an older adult when he's speaking. Because if they lose the flow, then they might miss out. It has happened to me that they might have come with a chest discomfort and they end up telling you about back pain and go back home. And then they call back and actually I had come to tell you that I have a chest discomfort, but I forgot to tell you. So shall I stop sharing this?
Sir, am I audible?
Yes, ma'am, you are. Sir, you can stop share.
Thank you.
Sir, I have this question just out of curiosity, because you
Yeah.
mentioned it is more about communication than about all your other medical things. Of course, there are medical things which are counted in this. So I'm just saying, like you mentioned that there are very few centers that are for elderly that are there. And I being from Uttarakhand, it's still more lesser. But for a place like Delhi, you may have more things. But for a place like Dehradun in Uttarakhand, it is still more lesser. So my question, sir, is that if we want to have a center for the elderly, maybe like a daycare, will it be, how much of the center should the center have? How much of the medical and how much for otherwise? Like we can have otherwise things, we can hear them out, we can get them spend time more productively and stuff. So would that help them more? Like the medical part is there, but how much it should be the ratio, or should we have certain things? Like if you want to start a center ourselves, then what is the kind of thing that we should be looking at? If I was able to make it.
So I established this geriatric division in 2021 in my institute, and it's a single man show.
Okay.
I am the only doctor there.
Okay.
The problem with geriatrics is it will not create revenue. So it will be difficult to convince people to invest money. But I was lucky to have a director who has belief in our vision, and therefore he was ready to because that's why I keep saying this. It's about you. When you say it's about you, then it makes an impact. It's about the elderly, it's about older adults. When we say like that, it doesn't make an impact. But when you tell you a director that in 20 years of time, you will require a geriatrician to take care of you, that makes an impact. You need people because you will become stressed out if you are alone, as is happening now. But see, everything has a start. And as with palliative care, it is multidisciplinary. You need people with attitude than with degrees. Because what I said, the slides that I used for this session, it was also used for a session with priests. It's a Christian hospital that I'm working in. So there was a meeting of priests of different sections who were working at different places in Kerala. So they had a conference here, and my director invited me to have a talk to them so that they can go back and make a difference in their. And I found that the same slides could be used for them as well, because it's a universal phenomenon. So if you ask me how to set up a geriatric center, it would also mean, because I am working in a tertiary care center, it's a tertiary care hospital. So what you do in a tertiary care hospital may be different from what you do in a daycare center, in a respite center, and what is the need of your population? Is it dementia? Because whatever is done is a bonus. Because if there is nothing now, whatever you start is going to be a bonus.
I have another question.
Yeah.
You mentioned the fact that geriatric care is like an disciplinary team. It usually takes more than just a medical doctor, for example. So who would you say would be essential if you wanted to create a team that would work with a community of elderly? What kind of roles would be important to something like that?
As with palliative care, the team would have a social worker, a physical therapist, physiotherapist, a nurse or auxiliary nurse, a doctor, 4 people. But volunteers, trained volunteers, as we do with palliative care, if you can train people to identify delirium, identify depression, screen for. So I have not touched upon those things. There are many things which are hidden behind those 3Ds of delirium, depression, and dementia. So if you can screen for these things in the community, that will bring out. But there is a national program for healthcare of elderly, which is happening. But then with all national programs, and also COVID came in between, so that has also affected. COVID has done a lot of bad things to elderly people. It has increased the burden of depression. It has reduced their mobility. It has produced social isolation. It has worsened their comorbidities. They have become bedbound, homebound. So this is the ideal setup that you would have for a team. But then if you can have 4 people, it would be good. I said it has been 2 years and I am the only person in my group, and I am working with the Department of Medicine. I am an assistant professor in the department. So I make use of my postgraduates, I teach them, and through them, actually, I can cater to a larger population, the inpatient population. I have not gone into the community yet because the hands are already full, but plans are there, and slowly and steadily it will make progress, definitely. And it is a need. It is a need for our health, because why I do this is because it's an investment for my health in 30 years time. When I become old, when I become dependent, I need doctors and healthcare professionals who know how to treat an older adult.
Yes, thank you.
Any other questions to sir?
Would there, sorry, one more question.
Yeah.
Would there be some sort of checklist? So, you mentioned some of the indicators of frailty, some of the indicators of what is delirium. And in one of your slides, I was a little confused because it seemed like there was an overlap between delirium and dementia and depression, like the second example of being quiet, withdrawn. Those are also symptoms of depression, as I understand it. So is there some sort of like a checklist that people could use to, let's say, evaluate, uh, elderly outside of medical conditions? So to say, how are you doing on these parameters to understand your risk of, frailty or dementia or delirium? Is there something like any resource like that that is available?
There are a lot of tools, and that is
Okay.
the biggest problem.
Oh, okay.
Because there are a lot of tools which are used in Western countries, and geriatrics is a full-blown specialty in Australia, UK, US, and all these tools come from there, which can be adapted to India, and there are some tools from India as well. And as I said, behind those 3Ds, there are tools for screening for depression, for confirming depression. There are tools for screening for memory and for confirming dementia. There are tools for delirium as well, as the confusion assessment method. And there are brief versions of it. There are extended versions of it, which can be used in the hospital, which can be used in the community. There are a lot of tools, but it was a little out of the syllabus that we could do in 1 hour, and it could only make you confused. And about that question about someone being withdrawn with someone who had dementia, patients with dementia are prone for delirium. So in that example, somebody's wife was having dementia and she became withdrawn. She had decreased talk. She was not identifying the relatives when she got admitted in the hospital because she had developed delirium. And delirium is a fluctuating phenomenon. So that's why it becomes confusing for the healthcare workers as well, because in the morning I would have seen the patient and he would have been fine. But at the night shift, when the resident comes, the patient is totally aggressive, pulling things, running around. And in the morning again, he becomes okay. So when the resident tells me, if I don't know what delirium is, and if the resident tells me that this patient was agitated yesterday, I might even scold him for telling me, what man, what are you saying? Is this patient, you are talking about this patient, are you hallucinating and all? So it's important that you know how delirium behaves. It is a fluctuating sensorium. And this is reported by the caregivers as well. At times, my father seems to be okay, but at times he becomes agitated. He starts to run around. He starts to see things. He starts to beat people who are not around. He starts to hallucinate, etc. So there are tools available. These are all available online. But the problem is whether we will have to adapt it to our setting. Because if I have to apply it in Kerala, I need it in Malayalam. If you have to apply it in your state, you might need it in your language or in Hindi. Right. Because the language that the patient speaks. But there are tools available. There are tools from the ICMR as well. But I don't know how common. And I am also learning geriatrics actually. I am not an expert in geriatrics. I have done a fellowship, but I'm basically an MD general medicine. But it's out of interest in this that I am doing this. So core geriatrics, these tools are available, but as with every tool, they have their pros and cons. So you might not be able to totally rely upon a tool to say that this patient has this problem. But tools are definitely available. Tools are actually, too many tools are available.
Would you be able to share maybe some of the tools that you think are somewhat useful with Cinia, so that it could be shared with the rest of us as well?
So this SF care that I mentioned, actually they also provide the tools in those. You just go through that. It's a senior friendly care. If you just type, it's from Canada. They also provide the tools with it. What tool can you use, how to do it as well. The second one would be this 5Ms framework. It's from the US. They also provide these tools which can be used and how to use it. There are YouTube videos of SF care. Yes, SF care, senior friendly care, and 5Ms framework. It is from the US. These are all freely available, and you can just Google it. And they also give you the tools which can be used. And there are YouTube links which are provided with the resources, which also show how to administer these tools. And my job now is to convert it to native language and make it valid so that we can use it in our hospital. Otherwise, you'll have to read it in English, make it in your language, and ask the questions in your language. That can also be done. There are also tools from the WHO. which are available, and in Hindi it is available actually. I don't get the name right now, but everything there are overlaps. But when you use tools, you should know what for you are using it. Whether you are trying to find out dementia, or whether you are trying to find out cognitive decline alone, or whether you are in suspicion, whether, so first you need a suspicion whether the patient has a memory problem. So somebody's mother leaving the gas on and going out of house, that could be a significant problem. But on and off, we also forget where we kept our keys. That need not be dementia. That is just forgetfulness. It's important to differentiate between the two. But when an older adult has problems with daily activities, and when you see such things, it is better that you get them evaluated.
So just wanted to ask on the similar lines as Lakshana just asked. Basically, there is a tool called VSMS. I'm just talking a little afar, but there's a tool called VSMS that helps you to find the social age. I'm talking this because one of the persons known to me, she is doing her MPhil in psychology. So she was trying to develop a similar tool like VSMS for elderly to trace traces of dementia or any such kind of conditions that may exist. So like you mentioned, there are several tools, and you mentioned that SF, that senior care thingy, so that it will be having a similar kind of a tool approach. Just for my clarification. VSMS is the Viniline social, it has got some tasks that are mentioned, and then you go by every year.
There are tools which have tasks. So it depends on who is administering the tool.
Correct.
So it would be easier if it doesn't have tasks, because even if I can train college students to go to the community and screen, this WHO has I don't get the name now. I'll make sure it
just try and share it with us in that.
Sure.
Like she mentioned,
and it has been adapted to Hindi.
Okay.
And the YouTube link is also available. I will share it.
Even if it is in English, it's perfectly fine. We can translate, because that's what we keep doing in the other institute that we go to. That we translate the VSMS completely into
Any of the tools will be fine if you just want to find out.
Yeah, it has to be Indianized. Yeah, and it has to be an Indian context. That context, if it has been done and worked on, then it's fine even in English.
But when it goes to research, then we have a problem. We'll have to validate the
research. Right, sir. Right, sir. Right, sir. So we'll look forward to that tool in that case.
Sure.
Thank you so much.
Any other questions to sir? We have got another 7 minutes, if any.
It is called the ICOPE tool. ICOPE. Integrated care of older persons. ICOPE. ICOPE. You can Google it. It is from the WHO, and it has been adapted to Hindi by, if I remember right, by Dr. Arvind Mathur from Rajasthan. The YouTube link is also available. ICOPE tool. ICOPE, which is a screen, and even Palim India has produced a comprehensive geriatric assessment tool. I understand that there was a questionnaire that was made. I had a discussion with Dr. Sunil. He had sent me. It was a beautiful one, which we could use for comprehensive geriatric assessment. But that would require a lot of time and person, because different parts have to be filled by different persons. So it depends on where you work and what you are up to, and whether what tool you use. Because a tool that I use in the hospital inpatient may not be useful in community. But ICOPE is a simple tool which can be used by college students. And the YouTube link shows a college volunteer going to a home and administering it to detect these early problems of vision, hearing, memory, etc. ICOPE, ICOPE.
Sir, and you, sorry, even I have missed the first part, the first 15-20 minutes, even I was not there. So you had mentioned about the dementia that is reversible and non-reversible. Would you like to add something into that, or if you go back to the recording, we will get enough on that? Because I missed it, that's my problem. So if I go back to the
I
recording,
have not mentioned anything about dementia more. What I told about reversible dementias are because people come with memory disturbances and we do certain tests, we get the history because infections like HIV can present as dementia. Hypothyroidism, thyroid disorders, people with low thyroid hormone in their blood, they can also have memory problems. So when we, in the first setting, when we send for investigations, and if the TSH comes out as very high, so administering thyroxine will reverse their memory problem. So that's called the reversible dementia. Then people with tumors of the brain. A tumor of the brain can also present with memory problems, behavior problems, and you do surgery for that, and the patient will be normal as before, depending on what type of tumor he has, where the tumor was, etc. So those are causes of reversible dementia. So dementia or memory problems are not always reversible. And that's why the importance of seeking healthcare or seeking help at the earliest. When you identify that someone older has problems with memory. And there are patterns for each type of dementia. Like as I said, for Alzheimer's dementia, there's a pattern. For vascular dementia, there's a pattern. There's Parkinson associated dementia, there's another pattern. So from this history, from how the patient has presented, from the caregiver getting the history from them, we'll be able to come to a reasonable conclusion about what type of dementia this patient would be having and what type of intervention should be helpful. And it is not pharmacological alone, it is more non-pharmacological than pharmacological, which helps. And it's the caregiver who is the lifeline of a patient with dementia.
Thank you, sir.
I think there are no more questions in chat. So I think we can wind up for today, sir. Thank you so much for this wonderful session in very detailed. And I think from now onwards, we will use the term older adults instead of elderly. Thank you for that wonderful session. We can see you with another topic on next Wednesday. Till then, bye. Take care.
Thank you. Thank you very much.
Thank you.